evening, everybody. I'd like to welcome you tonight to the symposium on optimizing outcomes for pediatric patients with EOE, the importance of timely integration of targeted biologic treatment. So tonight's panelists include myself. I'm Dr. Chris Liacouras from Children's Hospital Philadelphia, and you're lucky to have two other very experienced, outstanding physicians who deal with EOE, Dr. Kayleigh Menard-Ketcher from Colorado, and Dr. Jonathan Spergel, also from Children's Hospital Philadelphia. I'd like to thank Peer Review for providing the session and Regeneron Pharmaceuticals and Sanofi for providing the educational grant for the symposium. And if you haven't already, please complete the pre-event survey. As a reminder, look out for additional polling questions during the presentation and submit your questions and we will answer them during the Q&A session. Also, visit us at this following website, peerreview.com/EOE Hollywood24. There you can view all the slides and practice aids that we also will have, and you'll be able to download them after the event. Any more information, you can send an email to a peer review, and you can join the conversation on X at peer review. So the goals for tonight are to expand your knowledge of the benefits and limitations associated with the standard of care approaches to EOE, to enhance your awareness of clinical evidence supporting the use of targeted therapy in pediatric patients, and to provide guidance on the timely integration of targeted therapy into treatment plans for pediatric patients as deemed appropriate. The way we're going to set up the evening is that we have physicians who are going to give you three presentations, one on examining traditional treatment approaches in EOE, the benefits and limitations, another in making the case for targeted therapy in EOE, understanding the rationale and latest evidence, and the final one will be the importance of implementing targeted therapy at the right time, strategies for selecting the right patient. In between a lot of these, you'll see animated patient caregiver video clips, and you'll see polling questions throughout the evening that we hope that you will participate in. And then finally, we'll have an How I Think, How I Treat session featuring patient cases, and then following that, audience question and answer period. So be prepared to answer these questions that we poll throughout the presentations. So the first polling question is, please select your degree. Please select the category or role that best describes you. In the care of approximately how many patients with EOE are you involved each month? How many patients each month? Which of the following practice settings is applicable to you? How often do you adjust treatment for your patients with EOE based on their symptoms only and without doing another endoscopy? Which statement best describes the benefits and limitations of dietary therapy for managing EOE? How knowledgeable are you about the role of type 2 inflammation in EOE and the correlation between EOE and other atopic diseases such as atopic dermatitis and asthma? How often do you prescribe targeted biologic therapy for children younger than 12 years old who have EOE? And conversely, how often do you prescribe targeted biologic therapy for children older than 12 years of age with EOE? If you're evaluating a patient newly diagnosed with EOE who also has moderate to severe asthma and atopic dermatitis, which of the following best describes what you would choose as a first-line therapy? And what do you find most challenging about managing your pediatric patients with EOE? So we'll hopefully get back to some of those toward the end of the sessions, but what we're going to do first is give you a couple of presentations during the middle part of the symposium to help better understand kind of how we look at patients with EOE. The first will be examining traditional treatment approaches in EOE, benefit and limitations by Dr. Khalees Menard-Ketcher, who's an associate professor of pediatrics in the Department of Pediatrics in the University of Colorado School of Medicine. She also is a GI physician in the Digestive Health Institute at the Children's Hospital of Colorado.
Thank you, Chris, and welcome. So I'm going to talk about the traditional treatment approaches in EOE that have been the mainstay of treatment in the past few decades. But just as a recap, so the EOE presents in pediatric and adult patients, and the symptoms that people have really vary by age in terms of when they present to GI. So the younger children presenting more with feeding disorders, vomiting, abdominal pain in kind of school-age children, and then our older children and teenagers presenting really with a complaint of dysphagia and food impaction. The percentages on the right showing the fraction of population, these are their primary symptoms that they presented with the understanding that many patients really present with multiple symptoms when they come to GI offices. So this is just so that we're all on the same page of eosinophilic esophagitis. So these are the kind of the streamlined, updated EOE diagnostic algorithm that came from the AGREE meeting, which we'll touch on a little bit later in my talk. But essentially, when there's a clinical presentation suggestive of EOE, so some sign of esophageal dysfunction, but obviously many of those symptoms can be very general or broad and not specific to EOE when it comes to kind of feeding dysfunction or abdominal pain. But when there's suspicion, an upper endoscopy with biopsy is performed. So this is a clinico-histologic diagnosis where there's esophageal eosinophilia greater than 15 eosinophils per high power field. That has not changed. And the importance, though, is that we still need to evaluate and think about non-EOE disorders that could cause esophageal eosinophilia. Not all esophageal eosinophilia is EOE. But after you've gone through that process, you can make the diagnosis of eosinophilic esophagitis. Gone from this is the requirement of high-dose PPI failure. But all of this can lead to really diagnostic delay in EOE, and diagnostic delay is quite common. So the time between symptom onset of EOE and diagnosis in this study of over 700 patients with EOE range from 1 to 3.5 years in children and really up to 8 years in adults. So the findings showed that the time gap really increased as the patient age at diagnosis increased, and the median time for symptom onset to diagnosis is shown there. One thing that we are doing better is that the presence of food allergy and atopic dermatitis is associated with a more prompt diagnosis, and so whether this is recognition from the pediatricians or the allergy and working in close collaboration, more of these children are getting diagnosed sooner. But all of this really results in the burden of EOE. So by the time patients show up to our clinic with diagnosis of EOE, they really already have a lot of burden associated with the condition, related to symptoms. So of course the dysphagia, vomiting, food refusal, and a lot of feeding dysfunction that can be seen and affect families. Their comorbidities and complications, so if they have allergic disease, if they've developed stricture and narrowing of the esophagus leading to further dysphagia. This also results in psychosocial impacts in terms of the burden, so the symptoms around eating, pain, discomfort, missed school days, whether it be related to not feeling well or appointments to see physicians, and the social difficulties, because eating, as we all are doing right now, is just such a social pervasive part of our time. And so when you really are in pain and uncomfortable with eating, it really can affect your psychosocial functioning. And then, of course, the financial cost to families. So there's a direct cost of all the outpatient visits, endoscopies, et cetera, and the indirect cost of missed work days, particularly if you're a parent with a child needing all of these visits. So timely diagnosis, though, really does help with timely treatment and hopefully improvement in the burden of disease. Here's a film that just shows, from a patient perspective, their burden related to eosinophilic esophagitis.
Brianna's symptoms started around 8 weeks old. She had trouble feeding. She was labeled failure to thrive. She could not keep a lot of formulas and breast milk down. She started having diarrhea and then constipation, kind of back and forth that we couldn't get under control, and a lot of acid reflux. So those were her first symptoms. We were always very strict with the food, with the elimination diet, and I would say that that's probably been the best, it's been the best treatment for us. The slurry, I was very concerned about. So we got off of that. She still takes a daily PPI, and she takes Montelukast, and she takes an anxiety medication as well, since, you know, as she's gotten older, she's had some more anxiety coming along with it. So
I used to have 16 allergies whenever I was first diagnosed. I can't name off exactly what all of those 16 were, but the ones I currently have are peanuts, tree nuts, dairy, wheat, fish, shellfish, beef, and corn.
yeah, so when we first found out that she was that she had EOE, she did avoid 16 foods. That made it very tough. We got very creative in the kitchen. I remember going to the grocery store right after the diagnosis and finding out the things that we need to avoid. I spent 2 hours in the grocery store. At one point, I sat down on the floor and cried.
So I hope that video really exemplifies for everyone that the condition itself, when they come with symptoms, there's a lot of burden, but the treatment also has burden. And so one of the things that I think is really important as providers is try to lessen that burden, both in terms of making them feel good, but making the treatments that we help these families select through shared decision-making can be done as the best as they can be for the families. And so that really comes down to the importance of multidisciplinary approaches to management of EOE. And I'm very fortunate that I get to practice with all of these people really on the same day in the clinic. I get to work as a gastroenterologist with an allergist, a dietitian, and a feeding therapist, as well as nurse educators, and also have access to behavioral health support for the patients with eosinophilic esophagitis. That's obviously not available to everybody who cares for children with eosinophilic esophagitis. But I think the importance of finding people in the community or in your healthcare system that you can partner with who understand, that you can refer to help patients, whether it be a dietitian, which is absolutely essential if you're going to do a food elimination diet, allergists if they have comorbid disease, feeding therapists, and behavioral health support are all really key members of the team. So the suggested approach to management, so we're going to switch into the management of eosinophilic esophagitis, and there's a practice aid if you'd like to download that. But really, so esophageal eosinophilia greater than 15 eosinophils per high power field is the mainstay, so it requires endoscopy. But you need to consider other diagnoses. Not that you have to test for every one of them, but still have to go through the mental algorithm of whether this could be reflux being the most common, and then less common achalasia, lichen planus, caustic infection, et cetera, et cetera. And EOE, of course, is limited to the esophagus, but there could be eosinophils in other parts of the disease, and that would be considered more broadly an eosinophilic GI disease. So you have the diagnosis of eosinophilic esophagitis, and then really key is the shared decision-making approach. And this takes time, and it really depends on the patient's-specific goals and motivation of the families and how severe their disease may be when they first present to you. But often favored still as an initial approach due to cost and safety profile is the use of PPIs twice daily. It's not the most effective treatment. Only 30 to 50% of patients are PPI responsive when we use twice daily dosing. But again, it's easy to take and it's cheap. The next are shared decision-making around food elimination diets, swallow topical steroids, and then dupilumab more recently. And so each one of these has pros and cons to it that we'll talk about and touch on. But the goal with any of this is that we treat to target, and we ideally make our patients feel better. So at the top of this is symptom activity. Do our patients feel better? But we know that eating and feeding is such a dynamic behavior that sometimes we can see improvement in histology before we see improvement in symptoms, and vice versa. So we also know that we need to not only rely on symptoms, we have to look at histologic activity. And I say this because, we don't want to, I always say to my patients, I don't want to have you taking a medication twice a day, every day, if it's not the right medicine for you, if it's not helping the inflammation and the endoscopic activity with regards to EOE. So it's really a three-tiered goal with patient feeling better, improved histology, ideally less than 15 eosinophils per high power field, some argument that maybe attempting to get even lower, and then the endoscopic activity. Does the esophagus look better? And we use the EREF system as a way of communicating that to ourselves and to our colleagues. So with that, have you revisit the question, how often will you now adjust treatment for your patients with EOE based on their symptoms only and without doing an endoscopy? Thank you for that. Okay, so proton pump inhibitors. So there has been a progression of our relationship with PPIs in the EOE world. And so in the 1990s, PPIs were introduced as therapy for reflux disease, but in which we were seeing esophageal eosinophilia at the time. In the 2000s, PPI response was really being used as a diagnostic criteria to differentiate eosinophilic esophagitis from reflux. And through that, a term developed, or a category or phenotype of PPI responsive esophageal eosinophilia. And there has been a lot of debate and question and both translational as well as basic and clinical work that has tried to understand really what is PPI responsive esophageal eosinophilia. And certainly some of those people may have reflux disease and other things of that nature. But it does appear that they really are Th2 mediated, and so they really are just another treatment. There are a group of patients who have eosinophilic esophagitis that are responding to proton pump inhibitor. So through the AGREE meeting, the PPIs have been really removed from a diagnostic criteria to a treatment for eosinophilic esophagitis. In 2018, PPI therapy is now considered a treatment for eosinophilic esophagitis. And again, on average, histologic response rate is about 40%. It has both anti-secretory and anti-inflammatory mechanisms. And again, it can be considered a primary therapeutic option, particularly for patients with mild to moderate disease, because it has long-standing safety profile, it's easy to take, and it's cheap. So the AGA Joint Task Force Guidelines for the Management of EOE continues through. And for dietary treatment, their recommendations are recommend using elemental diet over no treatment. And this is a conditional recommendation because there's moderate quality of evidence that it works, but it's obviously not sustainable for the vast majority of people. And then their second recommendation is that using an empiric 6-food elimination diet over no treatment. And again, conditional recommendation, which with low quality of evidence, but there have clearly been many studies, 10 of high quality, reported the effectiveness of an empiric 6-food elimination diet with an overall unweighted histologic response rate of 68%. But many of these studies were clearly not randomized or placebo-controlled. Okay, so what is the treating with dietary therapy? What is the rationale and the goals? So the rationale for dietary therapy is that from the very beginning, eosinophilic esophagitis has been shown to respond to dietary manipulation. If you put somebody on elemental diet, the inflammation goes away. And we know from both early clinical studies and then more recent basic and translational work that eosinophilic inflammation is precipitated by food allergens in eosinophilic esophagitis. So the goals of dietary therapy are to eliminate those food antigens to facilitate disease remission. But we also want it to be feasible for our families. So once this disease is under control, the goal of reintroducing foods in a systematic way, to identify dietary triggers to avoid with the least number of dietary restrictions possible. It is effective, and it can be acceptable for long-term treatment. It is a non-pharmacologic alternative. It can be used first line, and it really, again, the importance of partnering with a dietitian or nutritionist can maximize adherence and success because they have the time and they know the questions to ask to help families and to support them through this process. So what are the elimination diets that have been studied? So there's the 6-food, 4-food, 2-food, and 1-food. Generally, a 2-food could be whatever you say it is, but this is generally kind of the accepted when we talk about a 2-food versus a 4-food, what we're talking about. So milk, wheat, eggs, soy, peanut, tree nuts, and fish, and seafood. Dietary therapy has come a long way since I first learned about dietary therapy and was introduced to it. So we used to do on the right, which was the step-down 6-food elimination diet, sometimes even more. We would put patients on highly restrictive diets, do an endoscopy, see if inflammation was well controlled or not. If it was, then we would sequentially add foods from least likely to be allergenic or triggering to most likely. So that's on the right with the purple. This required a lot of endoscopies. So again, each one of those steps is another endoscopy to determine what the least restrictive diet would be. People have really moved with evidence to the thinking about a step-up elimination diet. One of the pros, though, I will just say for the step-down still, is if you have a family who just wants to know right off the bat, can a dietary therapy work for me? Can a food elimination diet even work? The step-down does get to that answer the fastest, of removing kind of all the foods and yes or no, but it's the sequential adding back of foods that can take a long time. Whereas the step-up elimination diet, most often with the two most common, which is milk and wheat, if that one shows that everything's good, you're done. You actually just need to now decide if you're going to introduce milk or wheat, and if not, you continue to go up the ladder. This is a meta-analysis of elimination diets in eosinophilic esophagitis. So we used to partner with our allergists, but I will defer this a little bit to the Q&A, but to help us really direct food elimination diets with different allergy testing. But what we have found is that really allergy-directed food elimination diets perform really no better than empiric 6 food elimination, 4 food, and 1 food. And some of the surprising things that have come out of 1 food elimination studies is that they seem to perform very similarly to 4 food elimination diets. So again, this kind of flipping of step up versus step down, which led to this study, which was a head-to-head, and there are very limited head-to-head studies in eosinophilic esophagitis comparing different treatments, but this was comparing 1 food elimination diet versus 4 food elimination diet in pediatric patients with eosinophilic esophagitis. And this was results from a multi-center randomized controlled trial that included children 6 to 17 years of age, with symptomatic and active EOE, and you can see that it included just over 60 patients. They were randomized to 1 food elimination diet with milk elimination or a 4 food elimination diet. It was 1-to-1 randomization, but you can see that fewer people finished the study in the 4 food elimination. They were followed for 12 weeks and then had changes from baseline with regards to symptoms as well as histologic and endoscopic scores. And so there was improvements from both elimination diets, and they were similar in both patient groups, again suggesting that we could possibly start with at least a low restricted diet right off the bat. So with that, we'll have you answer this question. Which statement best describes the benefits and limitations of dietary therapy for managing EOE? All right, so moving on to topical corticosteroids. So the AGA Joint Task Force guidelines really have strong recommendation that topical corticosteroids should be used over no treatment. So none of these guidelines suggest one treatment over another. They're all suggesting treatment over no treatment. So, and again, this is because of data showing histologic remission, less than 15 eosinophil per high power field, really vary, but can be up to 84%. It provides a topical coating to the esophagus, and really topical corticosteroids should be used over systemic corticosteroids as they're safer, but show similar efficacy. There can be adverse effects, but they are rare. I'd be happy to talk more about these in the question and answer. So the practical approaches to using swallowed topical corticosteroids, there are several different mechanisms. We are borrowing in large part, except for recent data that I'll just review quickly, from the asthma world. So fluticasone, budesonide slurry, where we ask the family to be pharmacists in their own kitchen, ciclesonide, and then most recently the budesonide oral suspension, 2 milligrams, which has been approved for children over 11 and older. And then recently also phase 3 data coming out on a fluticasone oral disintegrating tablet, which is 3 milligrams daily. This is data from the budesonide oral suspension trial, so patients with EOE and dysphagia, so they were symptomatic, ages 11 to 55, were randomized 2-to-1 to receive either budesonide oral suspension versus placebo. And you can see the distributions there. And as you can see, there was a stringent histologic response in patients who received budesonide in blue compared to placebo, where only 1% improved, whereas over 50% with budesonide did. And there also was dysphagia response, with more patients receiving budesonide having improvement in their daily symptoms of dysphagia. With that, I'd like to pass it on to my colleague Jonathan Spergel, who's a professor of pediatrics at the Perelman School of Medicine at UPenn. He's the chief of the allergy section and the director of their Center for Pediatric Eosinophilic Disorders. And he's going to talk to us about making the case for targeted therapy in EOE.
Thank you, Khalees, and thank you, Chris, for all that information. So I'm going to be talking about, obviously, targeted therapies. So when we think about EOE from a mechanistic standpoint, we think about what other factors exist. So we know it's more common in men than women. There is most of these patients have atopy. We'll go over briefly some of the cellular mechanisms involved. It is highly hereditary, but it's not every twin gets it. It's more likely in twins, so there's an environmental factor, and there's some various genetic variants that we see that contribute to all these things. So one thing as an allergist, and these are patients we see all the time. I mean, these patients are highly atopic. So this is seen in lots of different studies, whether you look in pediatrics or adults, and whether you look at young children or sort of children 11 to 17. About just under 2/3 have seasonal allergies or allergic rhinitis. About half will have asthma. Young children have eczema or atopic dermatitis, so almost 2/3 will have eczema. About 1/3 of the older children and adults have eczema, and over 50%, up to 75% will have food allergies. And these are not the food allergies that Khalees was just talking about causing EOE. These are foods causing anaphylaxis. So it is really common. About 78% will have one, and about quarter will have all of them. So it's really, really common. So that's why it's important to work as a partnership, because these patients are pretty atopic. So we're now going to go over what that type 2 inflammation, where that classic atopic things come from in the inflammation of EOE. So we'll now share that video.
Eosinophilic esophagitis, or EOE, is primarily driven by underlying type 2 inflammation, characterized by immune dysregulation and epithelial barrier dysfunction. Mediators of type 2 inflammation include eosinophils, mast cells, Th2 cells that produce the cytokines IL-4, IL-5, and IL-13, ILC2s, and IgE-producing B cells. Th2 cells are a subpopulation of CD4 positive T cells, which secrete IL-4, IL-5, and IL-13 and stimulate the type 2 response. IL-4, IL-13, and IL-5 are key drivers of type 2 inflammation in EOE. IL-4 and IL-13 also contribute to the activation of mast cells and basophils, leading to the release of several inflammatory mediators. IL-4 and IL-13 drive epithelial barrier dysfunction, facilitating the entry of antigens that can worsen inflammation and increase access to allergens and pathogens across the epithelial barrier. They then propagate local inflammation, resulting in remodeling and fibrosis, such as furrows, distinct rings, edema, exudates, strictures, and increased smooth muscle contraction. IL-4, IL-13, and IL-5 also contribute to eosinophil activation and trafficking to tissues. IL-5 drives eosinophil differentiation in the bone marrow. Dupilumab is a fully human monoclonal antibody that binds to the shared alpha subunit of the IL-4 receptor and therefore inhibits IL-4 and IL-13 signaling. By inhibiting IL-4 and IL-13 signaling, type 2 inflammation is reduced, decreasing eosinophil count and improving symptoms of EOE, including difficulty swallowing, for patients.
So just to really summarize this, when you have EOE, I mean, you have this type 2 inflammation. The allergens, which there's a trigger that starts early on that activates the alarms, as you can see listed there, IL-33, TSLP, IL-25. These now activate our ILC2s that they just talked about. And these ILC2s now will cause our Th2 cells to become activated and cause the activation of the eosinophils along those lines. What happens is the IL-4 and IL-13 also causes the barrier to dysfunction, to make the barrier leakier. And then you get this increased induction of the allergens again coming in, leading to this induction. There's genetic risk factors, we know. Also, you also get activation of the TGF-beta and eosinophils and mast cells, which leads to the remodeling that we see, which causes a lot of the symptoms we see with our patients. And this is an ongoing cycle. Interesting, we talked about PPIs briefly. PPIs probably have a role on STAT6, which is an effector molecule of IL-4 and IL-13. That's probably the anti-inflammatory pathway that we think of about STAT6. So let's going back to the question that we talked about before. How knowledgeable are you now about the roles of type 2 inflammation in EOE and the correlation between EOE and other atopic disease such as atopic dermatitis and asthma? So now the question is, who should we put on? Why biologics for EOE? So there's a few different categories we can think of. One is we could think about patients who are not tolerating the other therapies that we talked about. Basically failing corticosteroids or having intolerance to steroids. We're also talking about patients who potentially now, because these patients are so atopic, that, hey, I can give you one drug that's going to target multiple different pathways and the multiple diseases they have. So these are patients like I see as an allergist who has asthma and atopic dermatitis. It doesn't work on IgE-mediated food allergy, but dupilumab is approved for multiple other diseases. And the other thing you can think about this drug, it is either, depending on the age and the weight, it's a weekly or bi-weekly medication instead of a daily medication. These are potential reasons why you may want to think about a systemic therapy for EOE. So what about the one that's been approved? It's dupilumab. As was mentioned, it blocks, is an anti-IL-4 receptor alpha. And IL-4 receptor alpha is part of a receptor that blocks both IL-4 and IL-13, which leads to the signaling of the JAKs and the STATs, which we won't go over. But the type 1 activates B cells, T cells, and eosinophils, while the type 2 really acts sort of on the fibrosis pathway, the epithelial cells, and smooth muscle cells as well. Dupilumab has been around for me as an allergy for about almost 8 years now. It's been approved for atopic dermatitis down to the age of 6, asthma down to 6 years of age, approved for chronic rhinosinusitis, with nasal polyps, which is basically really severe allergies, down to 12. EOE, originally approved down to 12 in May of 22, and now down to 1 in January 24. It's also approved for COPD. So it's really approved for multiple different types of atopic diseases. There have been 2 key clinical trials that led to the approval. One is the Liberty EOE Treat study. Sort of a complicated design, but you can really look at it as a Part A, a Part B, and a Part C. Part A was really looking at the weekly dosing versus placebo. You were on the drug for 24 weeks, then they did an endoscopy. Part B, they looked at 2 different dosing regimens, so weekly versus bi-weekly, so once a week versus every other week, again compared to placebo. The Part C was the long-term extension. Everyone was on active therapy, and they were looking at weekly versus bi-weekly. All patients had to have be symptomatic, so they had to have an active DSQ, which is dysphagia symptom questionnaire, had to be active. Patients had to be on current doses and stay on the current doses of medicines. At the primary endpoint at 24 weeks, which is shown here, you can see the improvement in DSQ on the 2 panels, on the panel on the left, looking at the weekly doses. There was a significant improvement compared to placebo at the weekly doses, but the every other week dosing really was not that different than placebo. In the other atopic diseases, that is the common dose we use. We use it every other week for asthma, atopic dermatitis. So in EOE, we needed a higher dose. Looking at histology now, both histology, whether weekly or every other week, had about a 60% improvement in histology. And this comes up to a really important point. Looking at eosinophil improvement is not the only thing you need to look at. You have to look at improvement in symptoms, as well as probably endoscopy things. There's drugs that knock the eosinophils completely out, which have failed in trials. It really points that this is more than just an eosinophilic disease. We have to look at other types of mechanisms. Now, this is looking at how well things are tolerated. It's generally been well tolerated. The most common thing we see is injection site reactions, and that occurs a fair amount in the patients. There's some tricks that we've learned over time, but you can see overall AE is about the same. There was been the rate of serious AEs versus active versus placebo were more or less the same in both groups. What about for the young children, the one that just got approved? Now, this again was a similar study design. Instead of being 24 weeks, was 16 weeks, so the patients were randomized to a high dose, low dose, and placebo in a 1-to-1 ratio. The low dose is what we typically use for atopic dermatitis and asthma. Then they got the placebo patients got randomized to a high dose and low dose, and we had a second endoscopy at the end of 52 weeks, and then there was an open label extension. And then after that, once the drug got approved, everyone got on to the real stuff. So this is what we saw. If you looked at patients who had less than 6 egos per high power field, so not 15, but 6, so really reduction, which was the FDA endpoint, there was about the patients in the high dose of just under 70% had improvement compared to about 3% in the placebo arm. Similar results, it was maintained when you looked out up to week 52. Looking at improvement in the EOE HSS, which is the histology score, which looks at other factors beyond just eosinophilic esophagitis. It looks at basophil hypoplasia, abscesses, dilated spaces. Again, significant improvement with the high dose and no change with placebo. And the other thing we looked at was looking at symptom scores. The problem with in pediatrics, we can't just look at dysphagia. As Khalees mentioned, there's lots of different symptoms. So this was a much more broad symptom score. So looking at days without symptoms, significant improvement in the high dose compared to placebo. This led to the approval of dupilumab at the high dose in the patients. AEs were very similar, and interestingly, the only AEs that led to discontinuation were in the placebo group, because these patients probably got more symptomatic and had trouble. The interesting thing also to look at this, what about patients who had good use of steroids or poor use of steroids? Didn't matter. It really didn't matter. So prior use of steroids, swallowed steroids or not, the groups responded the same, whether you were on a high dose dupilumab, had an improvement. Interesting, without prior steroid, the response rate was actually a little bit higher. They're probably a little less severe patients. The patients who had steroids were the ones who were failing. These are ones we typically get in clinical trials. But they had significant improvement in both groups, even patients who had failed steroids before. And it's even looking at whether you looked at EREFs, the histology staging, or a symptom score, which is the PESQ. This was the one that Charles evaluated. So what about one of the things we really worry about? This was some case reports that were just recently shown in an abstract. The patients who had really severe diseases, who had fibrostenotic, the thing that we want to prevent. Interesting, a lot of these patients, 2 of them interestingly had comorbid celiac disease, which is sort of like patients with EOE do get more celiac disease, get more IBD. It's sort of the opposite of what I learned as when I was a fellow many years ago. You couldn't get both. They were supposed to be separate diseases, but people do get both. And these patients, as you can see, had gone on everything, steroids, diet, prednisone. But looking at these patients, a lot of these patients had dilatations before, but if you look at the treatments for case 1, 2, and 3, they all got less than 15. 2 got completely normal. The most severe patient who was on prednisone, right, this is sort of a last resort, also got improvement. And you saw the endoscopy, what size the dilatation was able to improve, saying that, hey, over time, we might be able to reduce the fibrosis. This needs to be studied more, and work done by Khalees. Hopefully can look at it by EndoFlip, it can show that. So we're looking for work looking at that to see, hey, can we really show this is reversible? So now we're gonna ask the same questions we asked before. How often will you now prescribe targeted biological therapy for children younger than with EOE. Okay. Can you advance the next slide, please?
This is a new question. Please answer.
Oh, this is now older than.
Oh, how often will you now prescribe targeted biological therapy for children older than 12 years of age with EOE? So what about other biologics in the pipeline? So there's other biologics in the pipeline. There's something called sendakinumab, which originally was called RPC 4046, which just blocks IL-13. So IL-13 binds to two receptors, an alpha and alpha 2. The alpha 2 is probably considered a dummy receptor. The dosing for this is in a weekly sub-Q injection. The original clinical trials, which was shown here, looking at, we looked at two different doses, 180 and 360, and you can see the mean eosinophil counts in the high dose and the low dose showed improvement from a mean of 116 down to about 25 for both. Looking at EREFs, you see an improvement in both ones again, in the high dose and the low dose compared to placebo, which really didn't improve in this original study. They have now done a phase 3 study looking at 12 to 75 years of age, where they were randomized to the 360 weekly for 48 weeks in one group. The second group was randomized to 24 weeks of weekly, then weaning to every other week for 24 weeks, and the placebo group. The endpoints were similar, looking at peak eosinophil counts less than 6, which is the FDA endpoint they look at, as well as symptoms. You need to both have improvement in symptoms as well as improvement in peak eosinophil count. So looking at this, you're looking at improvement in endpoints. You can see compared to placebo, there was an improvement. About 28% had a histological improvement with the primary endpoints, and there's an improvement compared to placebo with dysphagia days. There's also improvement similar we've seen with dupilumab, looking at EREFs and dysphagia days, and there's about a 43% improvement for less than 15. And other things that are now in development, including tezolizumab, which is anti-TSLP. There's an anti-KIT antibody. There's one looking at a immune regulatory protein. There's a CYP1 modulator, and there's some case studies on JAK inhibitors. The anti-IL-5 drugs, anti-IL-5 receptor, and the anti-cyclic A, which eliminate eosinophil counts to 0, have all failed because they did not improve symptoms. But they improved eosinophil counts, and they actually didn't improve EREFs either. So now I will pass it back to Dr. Liacouras, who will talk about the importance of implementing therapy at the right time.
Thanks, Jonathan. Before I start this final topic presentation, just remember, we'll have some time at the end for questions. So if you have any questions you want to submit for us to look at, please do so. You'll have some time now to put them in as we're talking. So one thing I wanted to go back over, because again, I have probably the most gray hair in the room, but there's still a lot of young people who weren't around when this all first started. There were a lot of guidelines that were made in the first 20 years or so after EOE was first thought of back in the mid-90s. And the guidelines from 2011 still hold pretty true. I know they've been adapted somewhat in the last 5 years or so, but I just wanted to go over again to make sure you understood that EOE is really a clinical pathologic diagnosis. It's not cookbook medicine. It's not as simple as looking at tissue eosinophilia and saying there's 30 and 80 and we do this because of that. You really have to look at the clinical symptoms of the patients because they're all very unique and they can be a lot different in terms of what you might think about doing. And as we talk about what therapy to choose, that's going to play an important role, the clinical aspect as well as the diagnostic aspect and histologic aspect of how you choose what you're going to choose. Remember, it's just isolated to the esophagus. It's not like non-EOE EGIDs. It's not involvement in the stomach or the intestine, just the esophagus. And you have to have a decent number of eosinophils isolated to the esophagus. And as Dr. Menard Ketcher mentioned, you got to make sure that you have removed the other possible causes of EOE. Now, there aren't that many common causes of esophageal eosinophilia in the United States, and the two main ones are still EOE and acid disease, but there can be others, and we'll go over that again in one of the upcoming slides. Finally, I just wanted to mention that there was a consensus guideline in 2011 that characterized EOE as eosinophilic esophagitis represents a chronic immune antigen-mediated esophageal disease characterized clinically by symptoms related to esophageal dysfunction and histologically by eosinophil predominant inflammation. Again, doesn't mean that eosinophils are the only cause, and whoever may have been here yesterday for the single topic symposium know that people talked about other reasons why this disease may be happening, other immune characteristics and markers that may in the future be available to see why this disease occurs. But the eosinophil still remains one of the easiest ways to look at the esophagus for this disease. This is that same algorithm that you saw earlier, and we just bring it up again. And this is actually going to adjust somewhat slightly in the next year or so because it's just been kind of rewritten from the ACG, and it's going to come out in about 3 or 4 months. It'll be similar, but not quite the same, but it still works pretty well. And I just mentioned again from this algorithm that we're going to mention and talk a lot more about dupilumab in this last kind of session. So going back to how you decide what you're going to use, I've always been one, and the way we treat patients in Children's Hospital of Philadelphia is we really make this a shared decision-making process. Now, that doesn't mean there aren't specific patients that you can say, absolutely, you have to do this or that. I mean, there may be such severe cases that you tell them your recommendation and you have to do this or the child's going to be in big trouble. I'll give you an example. You know, let's say a 3-year-old who has severe failure to thrive and severe esophageal eosinophilia, and you not only need to treat the disease, but you need to put weight on the child, you may really push someone like that for getting enteral feeds and strict amino acid-based formulas because you're not only trying to treat the disease, but put weight on the child. Or an older teenager who has such severe esophageal disease that they have strictures that are so narrow and inflammation that you have to opt for much more aggressive therapy. So sometimes you really lead the patient and the parent on what you think is absolute, but many patients fit in the middle where you're going to use the patient and the parent in pediatrics to help you decide what therapy is going to work best. And it may change over time. So you want to make sure you purvey the types of treatments that are available, tell them what works, what doesn't, what they're in for, but you have to listen to the patient and find out what they really want to do, which will help you guide your therapy. So when you monitor therapy in general, and you heard this already, you can't just watch for symptoms. We know that symptoms don't always correlate, and often don't correlate with inflammation in the esophagus. So you need to monitor them, especially after any changes in therapy. And although symptoms can improve pretty quickly in some cases, and especially with dupilumab, we know that it takes time to see the true final effect of dupilumab. So to measure the true efficacy, a repeat upper endoscopy and obtaining biopsies is recommended 5 to 6 months after starting therapy. And again, that goes along with the clinical study that was done for older teenagers and adults who receive dupilumab. And then you don't have to absolutely follow that, especially if patients are not doing well. If they're doing well, that's a perfect way. That would be what I would say to do to make sure you have the best possible treatment and tissue outcome with your use of dupilumab. But let's say you put them on dupilumab and in 2 or 3 months they're still as bad as ever. You may want to change that, and you may need another endoscopy earlier. So you have to alter that thinking based on the patient's presentation and symptoms. So the criteria for the use of dupilumab, once it came out and was approved, there were several articles, and one was a yardstick in an allergy journal that was a nice article that looked at the possibility of when you would consider first-line use of dupilumab. And so in some cases, in patients who had other associated problems, as you've already heard, that atopic disorders can occur. And if someone has multiple comorbid atopic conditions like asthma or atopic dermatitis or chronic rhinosinusitis with nasal polyps, or those who have a strong preference to avoid dietary restriction, especially as children get older, teenage years, going to college, or they have a difficulty in taking swallowed steroids, or even are so bad that they need systemic steroids, there would be people that you consider maybe using dupilumab as a first-line or a more aggressive earlier therapy. Remember that in the older children and adults, dosing is weekly for EOE compared to every other week for other atopic disorders that have been using dupilumab, which again, those disorders dupilumab was being used even earlier than for EOE. But in younger children, EOE is given every other week, not every week. Other medications for the treatment of atopic conditions should be reduced or discontinued, especially after you start the dupilumab. And patients with EOE who currently require a maintenance dose, we're talking about asthma patients, of inhaled corticosteroids or long-acting beta agonists, or medium-strength topical therapies for atopic dermatitis can be reasonable candidates for dupilumab in addition to if they have EOE. So again, you kind of use clinical judgment in the history of the patient to help you determine if you can use dupilumab maybe earlier than you would have thought originally. When you think about using it as a step-up therapy, you obviously have plenty of patients who may be difficult to treat because your medication isn't working, or they're non-adherent to the medication, or they have significant disease, as I mentioned before, such disease that can't necessarily be adequately treated by using swallowed steroids or diet, or even systemic steroids in some cases. And there have been a lot of success with patients who've gone to dupilumab in those cases. Or patients who've had severe dietary restrictions and have been on either unbelievable diet restriction or even strict amino acid-based formulas. They're often candidates for earlier step-up therapy with dupilumab. For sure that those patients who are refractory to therapy or have histologic failure, easy to think about using a biologic. Certainly, again, chronic esophageal narrowing or fibrosis may be a possible treatment failure that you would think about going to dupilumab earlier. And patients who have issues with compliance, again, easier when you can take a medication once a week instead of multiple medications every day. But one thing you have to remember, though, is dupilumab is given sub-Q, and there are a lot of patients, especially younger children, who don't like to have a shot. And they'll often initially request doing other medical therapy, not because dupilumab wouldn't work, but because they don't necessarily want to get a shot. But as children get older and they see how often they have to take medication, or they're non-adherent and they have disease, parents and the children often start to believe that even one shot a week is worth doing because it might be more successful than being non-adherent to a daily medication. The other thing is you always have to look at is any adverse effects from current therapies. I mean, patients who are using multiple forms of inhaled swallowed topical steroids, and there may be concerns about adrenal effects, poor growth. Doesn't happen often, but it's possible. Then you start wondering whether or not a different alternate therapy would be of much more use. So let's answer this question before we finish up this kind of section. So rethink your choice. You are evaluating a patient newly diagnosed with EOE who also has moderate to severe asthma and atopic dermatitis. Which of the following would you choose as first-line therapy? Okay, so now we're going to look at another patient who this time, who this time also received dupilumab, and we'll see what their experience is with treatment and biologic therapy.
Since diagnosis, we were always put on a PPI. When we started seeing the doctors in San Diego, he was put on a slurry, which is a mix of budesonide with Splenda. He had to be on oral steroid every once in a while if he had like a big flare-up. As far as trialing food, he was able to trial a food like one at a time, but everything was a fail. Every single time we'd scope, it was a fail. And we just kept getting disappointment after disappointment, and he would have to go formula only again for, another 3 to 6 months before he would be able to try another food. When we started the dupilumab, he was on potato, even though it wasn't a true pass. And then we stayed on that for 6 months with the slurry and with the PPI. And when he scoped, he had his first ever, pretty much a clean scope. The lowest numbers we've ever seen. And then the doctor told us, let's wean him off the slurry. And they said, do you want to try 5 foods at a time, or 3 foods at a time, or do you want to try one big trigger, milk? And we've known milk was a huge trigger for him, plus he had the anaphylactic reactions to it. So we did that. We asked, and Carter said, I want to do the milk. And so we tried it in the office in case any reaction happened, and he did great. And then we scoped again, and again, low eosinophils on the dupilumab. So then we got off the PPI. So currently he's only on the dupilumab, no slurry, no PPI, and he scoped recently and still it was 0, 1, and 2. And so it's just been amazing, and he now has a completely open diet.
So this slide, I'm not going to go through every step, but this is going to be something you can obtain through the website. And it's a nice little kind of do and don't chart that may help you in deciding how to think about EOE and various treatments and diagnoses and the way you might approach the way you use endoscopy for these patients. So in summary, EOE continues to increase worldwide. I mean, back in the 90s, it was very rare and enough that most practicing academic physicians, both adult and pediatric physicians, didn't even believe the disease existed in the late 90s. But it's certainly now worldwide and talked about everywhere in almost every major allergy and GI conference yearly. It's a progressive disease. We now know that it definitely untreated can cause significant fibrosis and esophageal narrowing. The one thing it hasn't done is cause significant mortality, but it does cause a lot of morbidity and difficulty with quality of life. And so the earlier the diagnosis, the better not only for the patient, but to reduce any complications. And targeted biologic therapy is now available for even children after 1 year of age, as long as they meet the weight with EOE. There are other biologics that are also being developed. So we've made a lot of progress in therapies for EOE over the last 5 to 10 years. So this portion is going to be how I think, how I treat. I'm going to present a couple patients for the panel to discuss, to give you ideas of how we think. We may or may not all agree on exactly how we would do this in terms of what we would do for patients. But this will start the ball rolling in terms of clinical aspects of how we treat and think about EOE. And then hopefully we'll have other questions from the audience that we can address afterwards. So let's say we have a patient, a 12-year-old boy, who has a 4-year history of intermittent epigastric pain and a 1-year history of dysphagia without food impaction, and he also has some heartburn. He has a history of anaphylaxis to nuts and asthma, and has some mild allergic rhinitis. He was seen by a pediatric gastroenterologist and underwent an upper endoscopy that revealed a normal caliber esophagus, had some slight esophageal furrowing, but no rings, no white plaques. And biopsies were taken that revealed 20 eosinophils in the proximal esophagus and 60 eosinophils in the distal esophagus. He had a visually normal and histologically normal stomach and duodenum. And at the time of this endoscopy, he was on no medications. So I'm going to ask my colleagues, what would you do at this point? What therapy would you recommend? And what do you think the patient has?
I've been well trained by Dr. Liacouras here. Someone who has never been on therapy, I almost always start with a PPI. I mean, my mind, if you can get better with an over-the-counter medicine, I don't care what you're going to call the disease, whether you want to call it reflux, because he has heartburn, or you want to call it EOE, it doesn't matter. You've gotten better with a really simple, safe medicine. So I always start with the PPI.
I also would start with a PPI. I think in this case, while he has heartburn, and that certainly could be peptic disease or overlap reflux, I think the dysphagia, with him being male, and also atopic disease, I would call this eosinophilic esophagitis, but I would really talk to them about the use of proton pump therapy. Again, it's easy to take, it's cheap, it's safe, and so I would start with PPI therapy with a plan for follow-up scope, because it doesn't work in everybody.
I would agree.
Well, and the only thing I'm going to add is that there are some patients out there who have what we call classic EOE that's definitely food allergy driven, but could also have reflux too. There's sometimes people have two different things. So just keep all those kind of things in mind. That's why I keep going back to this isn't quite cookbook medicine. You really have to use your clinical judgment about what you're going to do. And to me still, and I'm again one of these gray-haired guys who started with PPIs, I still think that's an easy way to think about starting to make sure you know that isn't the whole deal. You'd hate to start some other therapy and they don't get completely better, and then you wonder, well, I missed my chance to use a PPI just for a couple months to really see if that had an effect. One of the big things that we always discuss and argue about is when you have a patient they presented like this with symptoms before you even know what the tissue is, would you start a PPI before you even do your first endoscopy or not?
This patient already had a scope, so it's easy. Would I start with someone who just has heartburn? I would start with the PPI first. If they have dysphagia and food impactions, I'm much more tempted to go to the EG first. So, maybe.
I would, again, in this patient with the dysphagia, I would go straight to endoscopy, but I completely agree with John Sperkel in terms of if the primary symptom was heartburn. I've been burned before where they come in with primary symptom of heartburn, but when you really do the digging, they do have dysphagia. So I think the importance of asking questions that you have high suspicion of to see if they do have dysphagia. I also have conversations with family. I think, again, this is another opportunity for that shared decision-making around families. Some families want to know, what is this? And other families just want their kid to feel better. If I'm going to start a patient on a PPI and they might get better, though, this is a patient that I make sure I follow up because they could have EOE, and I have treated it without them having the diagnosis. So this is not a patient that I just say, great, you feel better, go back to your pediatrician. This is a patient that I have them come back, I try to taper it, and I make sure I see them again at 1 year so I can follow up with their symptoms.
So I'm kind of agreeing and disagreeing. I don't disagree with anything. The way you treat is the way you treat, which is great. And I agree, you absolutely have to follow these patients. But I've found lots of patients, and it depends on the degree of dysphagia. That's the degree of symptoms you have. I mean, if you're talking about severe dysphagia where they can't swallow any solids or anything, sure, then you might want to do things a lot more rapidly. And there's even a second question here about what would you do? Would you think about even doing an imaging study to see what's going on? But I see lots of patients with what may be just simple reflux who say they have dysphagia. They've had trouble with some swallowing, but not severe at all. And they have heartburn. And I often think for me, because no matter what, I'm going to end up probably using a PPI anyhow, even if I did my first endoscopy and found eosinophils. I'm going to put them on a PPI first, aggressive, a significant dose of PPI, and do my first scope. And if it's normal, then at least I've kind of saved them a little bit. I've saved them maybe 2 endoscopies. But as Dr. Menard-Ketcher mentioned, you got to follow these people because you're going to want to eventually try to get them off the PPI and see what happens. And then you may have to go backwards, and if they can't come off, eventually do more scopes and see what's going on. But if everything is normal, you've saved a lot of headache. If you haven't done this with a PPI versus not. And again, this is your decision. You have to decide what you're willing to do. Dr. Spergel and I run a second opinion clinic, and we see maybe 20% of patients who come to us who are told or thought to have EOE. They may or may not have that, but were never tried on a PPI, and they were put on lots of these other therapies and never got better. And when we put them on aggressive PPI therapy, they get completely better. So again, you have to decide where you want to stand and how you want to make the right decision and what diagnosis they have. And to me, doing PPI earlier and spending just 2 months to figure this out saves a lot of headache down the line. Again, you have to decide on your own how you want to practice your practice. Do you guys agree that if you have severe dysphagia, you might want to do a barium study or something?
Yeah.
I really like barium swallows, barium esophagograms. We have worked with our radiologist, to actually also, if they can swallow a pill, to also give them a 13 millimeter barium capsule. Also, it's kind of a poor man's motility test, and it can help identify narrowing that might be smaller than 13 millimeters. So I really like them. I also, though, recognize, depending on the timing, it's another half day off work or school to get the test before the endoscopy. So depending, again, on the severity of this and things like that, I do just sometimes go to endoscopy, but I will, in that case, consent for possible dilation.
Yeah, that's the only question in my mind is when you go to endoscopy, if you have a contrast study to begin with, you might be ready to do a dilation.
Right.
Yeah.
And in
where you might
pediatrics,
not
we
have
tend to be
expected that.
a little more hesitant, so it can help you prepare.
Yeah. And then the other question is, and this is again something that, because I've done this so long, do you have to biopsy the esophagus? You definitely have to biopsy the esophagus in different spots to make sure you have the right diagnosis. But do you necessarily have to put them in different buckets for the pathologist? Like what I'm getting at is, just because you have a proximal esophagus in this patient of 20 and a distal of 60, what if it was reversed? Are you going to do anything different, really, with that information? And if you look at most studies show that the distal esophagus is usually more involved than the proximal. So I generally do biopsies everywhere, but I throw them all in one bucket. I don't know what you guys do.
We always split into 2, but again, the same thing. The data just says you need 5 to 6. It doesn't matter as long as you're surveying the whole esophagus. So again, I don't really so much rely on the location, but we still split.
I mean, if you're doing clinical studies, it's really
endoscopies.
important to separate things out. But
Yeah.
and then again, repeating endoscopies. When would you do that?
So we do them after you do when symptoms change, when you change medication, when you change diet. For steroids and diet, we do it usually anywhere from 2 to 4 months later. For dupilumab, we talked about it usually at least 4 to 6 months later after we do changes in doses.
Should we go to some questions, or do we have another case?
So we have, I guess we want to go to questions now. We have about 10 or 15 minutes left. There's a question here sent in what we call, or used to call PPI responsive EOE. So again, something that responded to aggressive PPI therapy where the eosinophils disappeared. How would you decide regarding therapy, how long to treat, what to do with it, how to decide, can they go on lesser therapy, that kind of thing? What do you do with that?
I mean, it goes a lot to your point about you have to kind of think really about how convinced you are that it's eosinophilic esophagitis versus is there possibly overlap, reflux, or other things? Like, could there be regurgitation, rumination, other things that kind of allow those eosinophils to be there? But I always try to get to lowest effective dose and helping families to determine if they can go to once a day PPI, et cetera. But when I do think it's eosinophilic esophagitis, if you stop the treatment, the inflammation is going to come back. And so often families sometimes want to try. And so if they do, I want to be supportive, but I will do a follow-up endoscopy.
So when you say try, would you go to, again, I'm not sure, I didn't ask this question to my panelists, but I'm very aggressive. When I use PPIs, I'm talking about using, a good dose, 1 per kilo twice a day, up to 40 twice a day. Big doses of PPI. Again, not over that, but pretty good dose. And for 2 months, I don't think you're going to hurt anybody, and you get your answer. And if everything works out, I think I'm hearing that you would you try to wean it, not necessarily stop it, but you say maybe let's go to once a day or something and see what happens.
Yeah.
And as Dr. Spergel said, our common practice is whenever you change your therapy, you almost always do an endoscopy. Except, I would say though, if in that case, let's say you're on a PPI or any therapy that we're talking about, and you show that the therapy is working histologically and the symptoms are gone. And then you start to decide, can we wean that medicine? And within 3 weeks or so, the patient has symptoms back.
Yeah.
Then you might not have to, to me, I'm thinking, well, what good is it to do a scope? I'm already going to probably increase the medicine.
Right. It's the same thing when we
let's save
do
the scope.
the same thing if we're adding foods or subtracting foods. Like, hey, the things are better and we've now, like, let's try adding milk back in. And now the patient is symptomatic and it's like, I don't need to scope you. Your dysphagia's back. You have disease, right? So it's the same thing. I mean, if we're going from normal to abnormal while we adding something back or reducing medicine, it tells me to be.
And it's because the symptoms and tissue doesn't correlate. That's the problem. And so if you have no symptoms, it's sometimes really hard to figure out what's going on without doing that scope. And you get really stuck if you don't do that, because then you make a couple changes, you finally find there is a problem, and you don't know what change was made. And that almost, I'm not sure we talked about this yet, but let's say someone isn't doing well and you're already on a PPI and swallowed steroids and you want to go to dupilumab or something. What do you do with the medicines they're already on? Do you stop them? Do you wait? What's your typical?
So what? It's going to be interesting because I don't think the two of us at least haven't discussed it yet either. I typically leave them on everything for at least to that first endoscopy. Then I start weaning everything off. It's like I want everything normal. Once everything's normal, let's now stop the PPI, stop the steroids. Let's go see how much you need, because I wean things down. But typically I will leave them on, whatever they're on, use it as an additive therapy and go from there.
So we've taken the approach because, again, the follow-up endoscopy for dupilumab is so much further out than the typical kind of 6 to 8 weeks for other changes that we might make, that I tend to try to wean them. I will start by taking away one, and I do it slowly, recognizing that I have time to potentially catch symptoms and to restart things. So I do try to see if I can do it with just a single modality treatment. So far, so good, but it's not always the case, so that could burn you.
Yeah.
Yeah.
And then we talked about medications, what you do, stopping, starting, following up with scopes. There was a question about what do you do with diet? Let's say you find out that someone is off dairy and they've done great. Symptom-free, tissue-free, everything's great. Do you ever reintroduce dairy? What do you do with foods?
So I'll answer the two-part to this. So one of the other questions, along the lines. So typically, we'll wait about 2 years before retrying the food back. For dairy, we'll often try baked milk first. Say, hey, you're completely avoiding milk. Maybe you can have milk in something. That will do much sooner. The data suggests about 50% of the people who got better on milk elimination can tolerate milk in things like cakes and cookies. The patient who on the video, who I would have never let them eat milk in their office alone, because they have a history of anaphylaxis to that food. So someone who has a history of anaphylaxis to that food, I would always allergy test it before adding it back in. Dupilumab has no effect on anaphylaxis. It has failed in those clinical trials. Someone who never had say someone who avoided potato was causing their EOE, but they didn't have anaphylaxis to it, that patient wouldn't need skin testing or specific IgE testing. I only test foods that they had a history of anaphylaxis before adding it back in the diet.
Jonathan, in your presentation, you were talking about other possible biologics and things that cause this disease. One of the questions was, is there any possible role for mast cell stabilizer drugs or biologics that look at other things other than...
So far they've failed. So, I mean, the cromolyn, right, failed completely, had no effect on anything. So that one we know was the mast cell stabilizers. The cyclic 8 inhibitor also inhibited mast cells. It also failed, so I'm not too optimistic as mast cell stabilizer from drugs. They don't seem to work particularly well. So right now we're looking at things that affect the T cell pathway more than anything else.
And then what about, it used to be 15, 20 years ago, we were hopeful that allergy testing might be of some benefit to give us an idea of what foods are a problem. Is there any role at all from EOE point of view?
From an EOE standpoint, the current allergy testing, whether you look at skin testing, specific IgE testing, specific IgG testing, no. There are some things in sort of research standards looking at T cell function. So maybe if you ask me this question in 3 years, I'll say yes, but right now, no.
I will just, as a gastroenterologist, though, I think the relationship when you're going to reintroduce the foods, as Dr. Spergel was saying, because if they have a distant history of having hives as an infant or toddler, and they're on an empiric food elimination diet, and now I'm going to introduce some of those foods, the consultation, the relationship with the allergist to make sure that I'm not putting that patient in potential harm's way by recommending reintroduction of a food that they really have had no accidental exposures to for years and things like that. So,
because there's been case reports of people anaphylaxing when doing that. So there's been several case reports. So it's.
And since we're on the subject of allergy, and I'm not sure there's any other questions related to allergy, the one thing that we're seeing more of, what about oral immunotherapy? I think we should just address that real quick in terms of, because people are getting that now, that and the relationship between possible EOE.
So what oral immunotherapy is, for people who don't know, so people who have anaphylaxis to a food, you can desensitize them, similar to allergy shots, right? But the idea now is you take the food and you add a little bit over time and you can make them less allergic. What happens in about 5 to 10% of the patients as you do that, they sort of get EOE to that food. So we see it, it happens, it's been seen in every single publication. It happens. There's no group that's, if someone says they're not seeing it, they're just lying to you.
they're not looking.
What?
They're not looking.
They're not looking. So you see in 5 to 10% of the time. When people do it, the answer is like, hey, you've gotten EOE to the food. You can either stop the oral immunotherapy. Most people don't want to do it. Then we just treat their EOE with dupilumab or a PPI or swallowed steroids.
So Khalees, I think we agree that you don't want to just throw a ton of things at somebody without knowing what each possible, I'm talking about drugs, what each possible drug may do. But what about if you have somebody early that you're not sure what's going on yet? Would you ever consider putting them on a decent dose of PPI and maybe just restricting dairy? Would you do those two things at once sometimes?
Yes, sometimes. And I think, again, it comes to the severity of the patient. So Just last week I actually had this conversation with his mom, and I'm going through the shared decision-making of the different treatments. And she just looks me dead in the and says, can we do more than one, right? Because her child, there's significant concern. The child is gaining weight appropriately, but there's so much work at home going on to get that child to grow. She just wants her child to be better and to take some of the pressure off. And so when we're talking about low-risk interventions, so working with a dietitian, getting this child a diet that is still sustainable, but removing the most likely food trigger and a medicine that is safe, I think that is an absolutely reasonable option. You can figure it out later after you get the kid growing and feeling better.
Yeah, just remember that if you do too many things at once, you sometimes don't know exactly what let's say you get a good result, what really was working, did they both work, was it one or another? So just make sure parents know that if you do that, you're probably going to, if your next endoscopy is normal, you're going to have to figure out which one of those two things, and it could be both, but was the real true factor that made the patient better.
So I'll answer one question quickly there's a question someone asked about conjunctivitis from dupilumab and EOE. So that's typically seen in patients with atopic dermatitis. It's not seen in other atopic diseases who were treated with dupilumab. The way you typically treat it, if it's mild, is actually standard allergy eye drops. If it gets worse, you typically will treat them with ophthalmic steroids. Often, if you're doing that, you send them to an ophthalmologist. There are some ophthalmic steroids that ophthalmologists consider safe. I can talk about that later, but typically not seen much in EOE, but if it gets bad, send them to an ophthalmologist.
What about, and this is more for Khalees just because we do the endoscopies, what about a patient who you're doing endoscopy for some other reason, possibly? Question about celiac disease or vomiting or something else that you're maybe not expecting to find esophageal eosinophilia, but oh, by the way, now you have 30 eosinophils in the esophagus that you didn't expect. What do you do with those patients?
Well, if they have celiac disease, that's a little bit easier. I put them on a gluten-free diet and see if the esophageal eosinophilia resolves with treatment of the celiac disease. With other patients, I think, again, it's that kind of shared decision-making. I have them come in. Oftentimes, there is some subtle symptoms that might have been overlooked, and so if I can pick up on symptoms, then I talk about the fact that it wasn't the reason why you came to see the gastroenterologist, but you likely have early EOE, and kind of talk to them again about sharing. If they're really asymptomatic and they're kind of looking at you like, why am I even treating this and why am I here? I do have a few patients where we monitor, and I really encourage them to come back every year because if, again, it wasn't transient for some other reason or peptic disease, they are very likely to develop symptoms as time goes on, and I want to try to catch it before they come into my ER with a food infection.
Yeah, I'm a little different just because I've been doing this so long. I don't ignore it. I mean, because of all the studies that have come out now, that if you leave this and delay the diagnosis, not everybody, but many patients will get into trouble. I'm a big believer in I'm going to treat that patient again with high-dose PPI therapy and then have them come back. And I try to explain to the parent, listen, I'm not 100% sure that they have something or not, but let's go through the steps and make sure. I worry about ignoring it just because it's there, it's real. I'm not talking about 2 EOs, I'm talking about a decent number. But that, again, no matter what, I think Dr. Menard-Ketcher's right, don't lose those patients. You got to follow those patients. You got to see them back. You got to see what's going on. You got to ask better questions maybe about could they have some subtle symptoms that you didn't realize. So, yeah, I don't ignore asymptomatic patients when you have tissue that's abnormal. So it's almost like, and again, this may be a terrible analogy, it's almost like ignoring someone who has a glucose that's 300, and they're going to probably end up with diabetes and they don't have any symptoms, but you don't want them to get into complications or worse. I just worry about that with the esophagus.
So there's some interesting questions. There's some that are short and brief, so I will just say, for anyone who does have a food infection, get biopsies at the time of their first endoscopy. There's posters here continuing to be this year, but every NASPGAN, there's another poster talking about the fact that if you get biopsies, you get more likelihood to get that patient back in your office to actually talk about the fact that they have very likely eosinophilic esophagitis. I've been informed, I haven't confirmed, but it's actually on surgical boards now in terms of food infections that biopsies should be taken at the time. So talk to your surgical colleagues or your ENT colleagues, whoever you share food impactions with, to do that.
And maybe the one question, because I think we're pretty close to time. One last question, since we're talking a lot about dupilumab, is you use dupilumab, it works great, symptoms are gone, you do your scope in 5 or 6 months, it looks completely normal. What do you do? And I think the jury is out, we don't know for sure, but in those patients, I'm going to think about, just like I would have with other medicines, maybe weaning that patient instead of every week, going to every other week or something. I don't know that true answer yet, but no matter what you do, what you change, you're going to have to follow up with an endoscopy. Does that make sense for you guys?
Yeah, I agree. Because we found when some patients do respond to the lower doses, so because we were using it before.
Well, I think that's it. I appreciate everybody coming. I hope you had a good time and learned something. It's an interesting disease, more to come probably in the next 5 or 10 years. More therapies will be out there. We'll know a lot more about dupilumab too. So thank you again very much.